Good morning, everyone. I'm Sherif Khaled, Professor of Orthopaedics, Cairo University. I'm going to speak about principles of acetabular fracture management. But before starting, I would like to acknowledge Professor Dr. Hazm Abdulazim and Professor Dr. Ahmed Hazm from Egypt and Professor Wael Taha from Saudi Arabia, as I used some of their slides. First, when you see a fracture like this, you look at the X-ray and you wonder what's happening on the right side. I think there is some sort of fracture of the acetabulum on the right side, and I can see as well a fissure, a small fissure here. And on the left side as well, I can see a fracture around here. The acetabular roof doesn't look normal, and the head doesn't look in place. It looks some sort of subluxated or dislocated. So we need to know how to read this X-ray, how to classify this fracture, and the principles of its treatment. So I hope by the end of this lecture, you will be able to interpret the radiology of acetabular fractures, describe the different fracture patterns, and outline the principles of treatment. Before starting to do this, we need to understand that the acetabulum has a peculiar anatomy. So it looks like an inverted Y-shaped letter, and it has a horseshoe-shaped articular surface. It has a long anterior column represented by the green and orange here, and a short posterior column represented by the blue. Also, the innominate bone has a helical shape. So there is a 90 degrees angle between the plane of the iliac bone and the obturator frame. So one view cannot show you both iliac wing and obturator frame equally. That's why we need to examine the innominate bone in two views, which are 45 degrees angle to each other. So when talking about the radiological evaluation, we start with an X-ray, pelvis AP view. Sometimes we do inlet and outlet for completion and for diagnosing associated pelvic fractures. We need acetabular Judet views, which are the iliac oblique and the obturator oblique views, which will show us the columns and the walls. And I will explain this later on. And in acetabular fractures, we need a CT scan, most of the time a multi-slice CT, taking acetabular cuts, which are usually thin cuts. And we need to examine carefully the axial cuts, the 2D coronal and sagittal reconstruction cuts, and the 3D reconstruction. On the AP view, we have 6 lines, which are the iliopectineal, or the anterior column, represented in dark blue, the red ilioischial line, or the posterior column, the teardrop in brown, the roof in yellow, the anterior wall in orange, and the posterior wall in green. When we look at the bone and the X-ray, the roof is the red part represented by this line. The anterior and posterior horns of the articular surface are represented by the teardrop, which looks like this brown line on the X-ray. Then on the iliac oblique view, we see the posterior column, or the ilioischial line, the red one, and the anterior wall, or the orange one. And in this case, the patient will be tilted 45 degrees. Then we do and this is how it looks on X-ray. This is the posterior column, and this is the anterior wall. Then we do the other oblique view. So we tilt the patient 45 degrees to the other side, and here on the obturator oblique, we see the anterior column represented with a dark blue line, and the posterior wall represented in green. And this is how they look on X-ray: posterior wall and the long anterior column. When the head is displaced or dislocated and the posterior wall is fractured, this is how they look. So you can see here the posterior wall is displaced and the head is dislocated. Then we come to the CT, which is very important in acetabular fractures because we need to know the classification of acetabular fractures. It will show us intra-articular fragments, whether large or small like this. It will show us if there is a femoral head fracture or no, the size of the posterior wall, if it's small or if it's large, the congruency of the reduction, the marginal impaction like the one you see here, and the quality of reduction post-operative. These are the classic CT cuts, and we start from 1 to 15. These are the classic cuts where we will see, number 1, the posterior wall. Number 2 is the anterior wall. Number 3 is the roof or the dome, where you see the shadow of the femoral head. 4 is the posterior column, and 5 is the anterior column. Also on the CT, you will be able to examine the sacroiliac joint and sacrum. You will see the anterior inferior iliac spine, cotyloid fossa, ischial spine, obturator canal, body of the pubis, and symphysis pubis. as well as the ischiopubic ramus. And this is how they look on an actual CT. The fracture patterns in the CT scan are very important because when you see a fracture that runs like the green arrow, then this is a wall fracture. When a fracture runs from medial to lateral, this is a column fracture. And when a fracture runs from anterior to posterior, this is a transverse fracture because it crosses all the lines and columns and walls of the acetabulum. Then we come to the 3D CT scan, which is, to my mind, it's not very important, but it's a nice imagination of the 3D configuration of the fracture and anatomy. And it shows us where the head is dislocated, in which direction, and it's a nice imagination of what you will see. Second, we move to describing the fracture pattern. To describe the fracture pattern, we need to know the classifications of acetabular fractures. And the most famous classification is Le Tournelle classification, where he divided the fractures of the acetabulum into 10 types. The 10 types were divided into 2 categories: complex fractures and simple fractures. And by simple fractures, he meant one fracture line. So we start with the 5 simple. The 5 simple are the posterior wall, the posterior column, the anterior wall, and the anterior column. And you all know this. Then the 5th one is the transverse, which has a single fracture line, but actually it's not that simple. Then the simple fractures are further subdivided into, the transverse fractures are further subdivided into 3 types. The infratectal, which is a very low transverse fracture. The juxtatectal, which is a transverse fracture that runs immediately below the roof. And the transtectal, which actually runs through the roof. And these are also described in the AO classification, the new compendium published in 2018 as B11, B12, and B13. Then we come to the complex fractures, which are posterior column with posterior wall, transverse with posterior wall, T-shaped fracture, which is actually a transverse fracture, but has a limb that goes down and exits somewhere between the pubic bone and the ischium. So it can exit here, 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 or there. Then we have another type, which is the anterior column with posterior hemitransverse, which is actually similar to a T, but with a high anterior column. Finally, the both column fractures. Sometimes we get confused between the both column fractures and the 2 other types, this one and the T. But look at the articular surface. If the articular surface is not attached to the axial skeleton, then this is a both column fracture. If a small part even of the articular surface is still attached to the axial skeleton, then this is not a both column fracture, or not an associated column fracture. A T or an anterior column with posterior hemitransverse. The AO classification classifies the acetabulum as 62, and it divides the acetabulum into 3 types, 62A, B, and C. And in the new compendium published in the Journal of Orthopaedic Trauma in 2018, they added all the variants. Then we move to the 3rd point, which is outlining the principles of treatment. And for acetabular fractures, we are going to either treat it conservative or operatively. So let's start with the conservative, who is indicated for non-surgical or conservative treatment. Fracture displaced less than 2 millimeters, then it's not worth doing it. Fractures below the weight-bearing area, like the infratectal. A stable hip with a very, very small posterior fragment, or a dislocated hip that is reduced and does not redislocate on examination under anesthesia. A both column fracture with secondary congruence, and this is a bit peculiar, so I found this X-ray in one of Dr. Wa'el Taha's lectures. Here you can see that the acetabulum is fractured everywhere, but it still maintains the rounded shape around the head. So we call this secondary congruence. Congruence is the containment of the head inside the acetabulum, and this is secondary because it's all fractured. So for example, if you have a case like this and the patient is 60 years old, you may treat him conservatively. Finally, when we have advanced medical problems and the anesthesia is going to force you to treat the patient non-operatively. Then we come to the management goals. If we're going to do an operative treatment, displaced acetabular fracture is an intra-articular fracture, and we know that for all intra-articular fractures, we need anatomic reduction, stable fixation, and early range of motion. So that's what we need to achieve. And when we achieve this, we decrease the risk of secondary arthritis, we maximize the hip range of motion and function, and we minimize the risk of our complications. We need to understand these rules very, very, very well before treating an acetabular fracture. Acetabular fracture in 90% of the case will require an open reduction in internal fixation to achieve an anatomic reduction of the articular surface. Adequate fixation of the columns and walls is essential. We need to reduce the head dislocation if the hip is dislocated. We need to treat the associated pelvic fractures and femoral head fractures as well. And most important, we need to plan all this before starting. So we need to plan the position of the patient, the anesthesia that we're going to use, the approach, and the implants. And that's very important. You will require these instruments, including Matta clamps, king tongue reduction clamps, pelvic reduction clamps, and bowl spikes. And you will require reconstruction plates, whether 3.5, 4.5, straight or curved, with long screws, because you may need the long screws for column fractures. How to fix it? We need approaches. We have many approaches available: the Kasr Al Ainy, the ilioinguinal approach. We have also the modified stopper approach and the iliofemoral, and I will describe these four. We have other approaches that are not commonly used, like the pararectus, the surgical hip dislocation, and the extended iliofemoral approach. First, we start with the Kasr Al Ainy approach. It's an approach that mainly aims at the posterior column of the acetabulum. So you will clearly see this dark blue or violet area. The red area is felt by the finger, and the green area will require some extension of the approach. And this approach, as you can see, is mainly needed for posterior wall, posterior column, for transverse fractures with posterior wall, and for T fractures, it's going to be one of the approaches that you will use to treat the T fracture. The ilioinguinal, this is an approach that is anterior, so mainly aiming at anterior fractures. We have three windows: one lateral window in the iliac fossa, one medial window in the cave of Ritzius, and one middle window between the lacuna musculorum, which is the fascia containing iliopsoas and femoral nerve, and the lacuna vasorum, which contains the external iliac vessels. This is the incision usually. This is where the lacuna vasorum is, and this is where the lacuna musculorum is, and this is the lateral cutaneous nerve of the thigh. And we use this approach, the ilioinguinal, for anterior wall fracture, anterior column fractures, associated both columns. It's one of the essential approaches. In transverse fractures, sometimes we need to use it. And in T-type, we need it for the anterior component of the fracture. And this is the lateral window in the iliac fossa. This is the medial window in the cave of Ritzius, and there is a small window here in between. So these are the accessible parts that you can reach through an ilioinguinal approach. For the modified stopper approach, the modified stopper approach is open midline. We stand on the other side of the patient because we see the opposite side. It can be done transverse or longitudinal, as whatever you like. It usually shows you the area outlined in red, and it is used for anterior wall fractures, anterior column fractures, medial wall fractures, especially if you want to use an infrapectineal plate, supratectal comminution, a T-type, a transverse type, and an associated posterior column with an anterior column. So this approach is very useful, and if you train to do it, sometimes it is an addition to your work. This is an example of the infrapectineal plate. The infrapectineal plate is very difficult to put from any other approach because the direction of the drill and screws, you can imagine the drill and screws coming from the other side. So this cannot be done through an ilioinguinal approach. It's almost impossible. Iliofemoral approach, or modified Smith-Peterson approach. And if you do this approach, you will access this part, the iliac crest here, the upper part of the anterior column. And combined with the Kasr Al Ainy, it can be very useful in associated fracture types. The quality of reduction, when we reduce a fracture, we need to achieve less than 2 millimeter displacement, and we call this anatomic reduction. And that's why fracture displaced less than 2 millimeters are treated conservatively, because the aim is achieved already. Imperfect reduction is a 2 to 3 millimeter displacement, and a poor reduction is more than 3 millimeter displacement. But this quality of reduction or outcome relies on experience of the surgeon. So the publications found that you can achieve good to excellent results in 75% of the cases treated in the first 3 months, in the first 3 weeks with an experienced surgeon, while for a less experienced surgeon or for a junior surgeon, this rate drops to 50%. So the outcome relies on experience of the surgeon. Beware of difficult fractures as well. Sometimes it's more complex when the treatment is delayed beyond 3 weeks. This will give you poor results. Also, if you have a femoral head fracture, a marginal impaction or a dome impaction, these are going to make your life more difficult. Let's go back to our case example, a 38-year-old police officer involved in a motor vehicle accident. I hope by now you can tell me what there is on the X-ray. When we look, this is an example of the axial CT scan. You can see on the left-hand side, there is a posterior column fracture, a posterior wall fracture, which is comminuted, and a femoral head dislocation. You can see also a marginal impaction, and you can see the comminution of the posterior column inferiorly. On the other side, you can see also there is a posterior column that starts up there, okay, and then a posterior wall, and then a marginal impaction. What are we going to do? So this is mainly posterior, so I'm going to use the Kocher-Langenbeck approach. And through the Kocher-Langenbeck approach, this small plate is for the column and the longer plate is for the wall. And here I used one plate for the column and wall. It depends on the configuration of the fracture inside. This is the iliac view. You can see the posterior column. This is a small plate for the posterior column. The small Herbert screw here is for the marginal impaction. And the 2 screws here are for the posterior wall. These are usually lag screws. You can take them outside the plate or inside the plate. And then the plate is fixed mainly with 2 screws up, 2 screws down. And this is for a comminution in the posterior column. On the other side, this is the posterior column. So the plate is holding the posterior column with 2 screws distal, 2 screws proximal. This screw is for the posterior wall. These 2 screws are rafting for the impaction, and another lag screw for the posterior wall. And this is the CT. You can see how the marginal impaction was reduced on both sides, and this is very important to evaluate. This is the CT of the patient after, I think, 6 months. Okay, let's move to another example. A 20-year-old male soldier involved in a motorcycle accident. And you can see here that the fracture runs there. So the articular cartilage is not attached to the axial skeleton. Then there is a medial wall. Then there is a fracture passing down there. So we can tell that this is an associated both columns because the ilium ends here. Let's look at the CT scan. When you see a fracture running from anterior to posterior, then this is the transverse component. You can see the anterior column component. You can see the posterior column component. And here you can see that the articular surface is not attached to the axial skeleton because the fracture goes up to here. Again, the fracture is there, so the articular cartilage is separated from the axial skeleton. I stress this point because this fracture is actually difficult to classify. Then I went through a stopper approach, which is very useful in this case. First, you fix the iliac crest, then the infrapectineal plate, and you can see how the infrapectineal plate supports the roof here and holds the fracture. Then we put the anterior column plate, as you can see, and fix it with screws anterior and proximal. Posterior column, I used 2 screws to fix it through the infrapectineal plate. It's a difficult technique to use, but it's sometimes very useful through the stopper approach. These are the post-operative X-rays. These are the 1-year follow-up, and you can see the reduction of the articular surface and the acetabulum. And to evaluate better, this is 1-year CT. I use a CT after in the follow-up as well to evaluate my reduction. So you can see the reduction of the acetabulum on both sides, and you can see the healing of the fracture after 1 year. So my take-home messages are that the acetabulum has a peculiar anatomy that requires special views and CT. There are 10 fracture patterns, intra-articular fracture, so it requires anatomic reduction, internal fixation to avoid secondary arthritis and complications. We have many available approaches, and each fracture pattern will require a different approach to fix. Difficult fractures to manage, and they have a very long learning curve, and that's why the experience of the surgeon differs in the outcome. Finally, beware of femoral head fractures, marginal impactions, pelvic fractures, and other predictors of poor outcome associated with an acetabular fracture. Thank you very much.